Test, 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 test. Okay. Lisa, can you hear me all right?
Yeah.
Okay, good. Uh, Oh, we are recording. Okay, good. Here's the on these. This is not an easy group of drugs. So we're kind of starting with the hardest to digest meal, I suppose you could say. This particular group of drugs in general, the antipsychotics, are not simple. They take a lot of managing. They've got some nasty side effects. And you have to manage them. So without further ado, why don't we start with a word of prayer? Gracious Lord, we thank you once again for this day. We thank you for all you do for us. We thank you most of all that we get the chance to get an education. We thank you for these young men and women who want to be healers. We pray, Lord, you continue to confirm that calling every day in their lives. Right now, help them learn how to manage this tough group of drugs. In Jesus' name, amen. So when you think of psychosis, tell me what you think of. What comes to mind when you hear the diagnosis, psychosis? Just give me some shout outs. Crazy. All right. Crazy. Not very clinically useful, but I suppose it fits generically. What else when you hear psychosis? What do you think? Erratic behavior. Erratic behavior. Erratic behavior caused by what? potentially hormone imbalances. You think of maybe hearing voices. Voices are telling them to do certain things. So there's a basic loss of reality. They're hearing voices, they're seeing things, what have you. And these hearing voices, seeing things are driving them to do things that they normally wouldn't do. So those are what we call the positive symptoms of schizophrenia. These drugs largely work on the positive symptoms of schizophrenia. They don't really work on the negative symptoms of schizophrenia. So positive symptoms are things that are added. Hallucinations, auditory hallucinations, fear, what have you. These are added. Negative symptoms have to do with things that are taken away. Schizophrenic patients tend to experience something called alogia. They don't talk very much, or their speech is extremely disjointed, or they have a tendency to not show much affect. Those are negative symptoms as well. So the first theories of schizophrenia predicted that schizophrenia was due to excessive dopamine neurotransmission. Now, this is probably part of schizophrenia, but this theory is wrong. It's very clearly wrong. So all antipsychotics have this in common in that they reduce dopamine transmission in the brain. They all have that in common. So there are first generation antipsychotics, that's what FGA stands for, and there are second generation antipsychotics. First generation antipsychotics bind to the dopamine D2 receptor and they antagonize it, they block it. They prevent dopamine from binding to it. And they do reduce the positive symptoms of schizophrenia. They have lots of other side effects, though, consequently. Now, the second generation antipsychotics have a different strategy, and we'll see what those are in just a bit. They tend to bind the D2 receptor, not tightly, but they tend to bind and come off, and bind and come off, and bind and come off. So they don't spend as much time bound to the D2 receptor. They don't have as high an affinity for the D2 receptor. So they decrease neurotransmission from that receptor, but they don't completely block it. And there are a new group of second generation antipsychotics that are D2 receptor partial agonists. Partial agonists. They bind and occupy the D2 receptor, but they only activate it partially. They activate it a little bit. So let's review the dopaminergic pathways in the brain. There are 4 of them. So the first one starts in the ventral tegmental area, and it goes from the ventral tegmental area, as you can see, and it tends to go to the prefrontal cortex over here. And this is the mesolimbic pathway. This is the one that is associated with rewards. The second is the mesocortical, and it tends to originate also at the ventral tegmental area, and then it goes through the forebrain, essentially. Many connections into the forebrain. Third one is the nigrostriatal system. This is the one that's involved with controlling voluntary motion. It starts at the substantia nigra and goes to the basal ganglia. So this is the one that's involved with the direct, indirect pathway of the basal ganglia. Finally, there's one pathway called the tuberoinfundibular pathway. You have dopaminergic neurons that extend into the pituitary, and they use dopamine to regulate prolactin. They regulate prolactin. So prolactin inhibiting hormone is dopamine. So let's think about this. If you block dopamine signaling, what's that going to do to voluntary movement? What do we call that when you have a disease that interferes with dopamine-mediated voluntary movement in the basal ganglia? I'll give you a hint. They walk like this. Parkinson's. These drugs can cause Parkinson's syndrome. It's called pseudo-Parkinsonism, because you don't really have Parkinson's, but the drugs can cause you to have Parkinson's. If it blocks prolactin, what's going to happen sometimes if you block dopamine neurotransmission? What do you think will happen to prolactin? Show me with your thumb. It's going to go up, right? Because it blocks prolactin, it's going to go up. What happens if you get too much prolactin? What does prolactin do? Ladies and gentlemen, this is not a staring contest. Come on, answer me. What does prolactin do? Sorry? When you go down? When it goes down. Would it go down? No, it goes up because dopamine inhibits prolactin. So what happens when prolactin is overproduced? Prolactin. It sounds like, yes, you can cause women who aren't pregnant or have delivered to start lactating. That can happen. In guys will tend to have erectile dysfunction and they'll tend to become sterile. Their sperm production goes down. Would that be a drag if you're a guy? Okay, everybody do this. Yes, that's a problem. So it's clear that this pathway, the mesolimbic pathway, seems to be overactivated in people with schizophrenia. That's due to PET scan data. Now, again, PET scan data, you got to take it sometimes with a grain of salt, but it's a pretty consistent result that this particular dopaminergic pathway is hyperactivated in people with schizophrenia. And it's clear that drugs that can induce psychosis increase dopaminergic signaling in that pathway. So drugs like cocaine, amphetamines, L-Dopa, all these drugs potentiate dopamine neurotransmission and can cause psychotic episodes. So the dopamine hypothesis does not explain the cognitive defects of schizophrenia, the flat effect, the alogia, things like that. Also, there are other drugs that can induce schizophrenia that don't have anything to do with dopamine. The big one is LSD. LSD is a serotonergic drug. It can induce psychotic breaks, and it's got nothing to do with dopamine. So is this hypothesis useful? Yes. Does it explain everything? No. So let's talk first about the first generation antipsychotics. They're really not used that much today, with the exception of haloperidol. Haloperidol. Haloperidol is used a lot in emergency departments if people are admitted and they're unmanageable. Haloperidol is pretty sedating. And they're usually given haloperidol in combination with some other things to make them go to sleep. The cocktail is called a B52. Any of you heard of a B52? Not the drink. Okay, Howard, imagine you might have given a few in your day. It's called the B52 because it has 50 milligrams of diphenhydramine and 2 milligrams of haloperidol. And then it has something, lorazepam? Do you know what else is in it, Howard? Yeah, it's got something else in it, but basically after B52, it's buenos noches, gringo. It's you're out, pal. And you do that if someone is just unmanageable. And if anyone, you guys will work ED, some of you. When schizophrenic comes in and they're violent, they're biting, they're trying to bite you, they're trying to hit you, they're a danger. They're a danger to everybody. You just have to put them out. So first generation antipsychotics bind the D2 receptor tightly. They shut it down. Some of them also will inhibit these other receptors as well. The histamine H1 receptor, if you inhibit the H1 receptor, it's going to be sedating. The M1 receptor, that's a muscarinic receptor. That means you'll have antimuscarinic, anticholinergic effects. And then the alpha 1 receptor, that means it'll tend to drop blood pressure. Second generation antipsychotics also get the name atypical antipsychotics. These drugs are used far more commonly today than the first generation ones. First generation ones have a lot of side effects. That's why they're just not used that much. So the second generation antipsychotics, they dissociate quite rapidly from the D2 receptor, and they have serotonergic, anti-serotonergic activity. In particular, they antagonize the serotonin. 5-HT is 5-hydroxytryptamine, which is serotonin. The serotonin 2A receptor. That receptor seems to play a role in schizophrenia as well, particularly in the mesocortical tract. So the first of the second generation antipsychotics that was discovered was this drug clozapine. Clozapine today is your howitzer. If nothing else works, you go to clozapine, and it usually works. Clozapine has a tendency to mess with bone marrow and cause agranulocytosis. So if someone's on clozapine, you have to keep checking their blood to make sure that their bone marrow is still working. If it's not, they have to get off the clozapine. So it seems now the dopaminergic theory has been refined based on these new data, namely that by antagonizing the 2A serotonin receptor, you increase dopaminergic transmission in some of the other pathways, like the nigrostriatal pathway and then the mesocortical pathway too, thereby reducing the symptoms of schizophrenia without a lot of the nasty side effects you saw with the first generation antipsychotics. And that's why it can theoretically increase dopamine signaling in the prefrontal cortex. Now, there are problems with this particular theory. Namely, you can do labeling studies, and you can see how long these drugs occupy the receptors. And it's not always clear that the ratio of serotonin 2A to D2 antagonism predicts the potential side effect profile of the drugs. Having said that, it is clear that the second generation antipsychotics cause a lot less Parkinsonism. So the Parkinsonism, those are called extrapyramidal symptoms, or EPS. So by this, we usually mean Parkinson-like symptoms. So Parkinson-like symptoms would be the resting tremors, the shuffling gait, the mask-like affect, inability to prevent unwanted motion, tics, that sort of thing. So here again, first generation antipsychotics bind very tightly to the D2 receptor. Second generation ones bind loosely. And this picture is simply meant to illustrate that. Whereas the second generation ones bind and get off, and then dopamine has some access to it. First generations, they shut that receptor right down. And there are a few of the second generation antipsychotics that are also agonists for the serotonin 1A receptor. What's the significance of that? Well, it seems to increase dopamine release in the prefrontal cortex, seems to calm down glutamate release. Remember, glutamate is the major excitatory neurotransmitter, so it might help somebody be more even-keeled. That's the idea. And they have some effects on intracellular signaling as well. So, based on PET scan sorts of experiments, and here's the paper that looked at this, they asked the question, how much D2 receptor occupancy leads to extrapyramidal symptoms versus antipsychotic efficacy? And it turns out if the receptor is 60 to 75% occupied, you block psychosis. You block the psychosis type symptoms. So there's a pronounced antipsychotic effect. Once you get above 78%, now you start to have the extrapyramidal symptoms, Parkinsonism, and so on and so forth. So if we compare these two drugs, first generations are going to mainly live with D2 antagonism. Second generations are going to antagonize the serotonin 2A receptor and the D2 receptor. And they might have some off effects as well, depending on the antipsychotic. So the first generation antipsychotics are interesting historically. They're sometimes called neuroleptics. If you hear that term neuroleptic, it refers to a first generation antipsychotic. So they will tend to cause psychomotor slowing. So their entire brain kind of just slows down in general. They cause emotional quieting, which can be useful in some cases. And they cause affective indifference. So these are the drugs that are associated with turning somebody into a zombie. So think, Resident Evil. So the typical antipsychotics They were really used quite a bit, and in some parts of the world, they're still used. They are effective, but the trade-offs for these drugs was really just considered to be too much. All right, so if we then, this just tries to show you those different pathways in color, and you can see how they work. So here are these drugs, and again, I'm not going to be too concerned about these particular drugs. The big one that you need to know is haloperidol. And there it is up there, haloperidol. These others, I really doubt any of you will ever use them. So I show them up here for completeness, but out of those, go ahead, take your marker and just mark haloperidol. That's the one you need to know. The others, don't worry about them. And yeah, you get the points. Okay. So the first generation antipsychotics, they're the typical antipsychotics. They will shut down dopamine neurotransmission in all four dopaminergic pathways. They don't differ in effectiveness, they differ in potency. So high potency, haloperidol, low potency, chlorpromazine. And then this leads us to the second generation antipsychotics. So these have a lower risk of extrapyramidal symptoms. You would expect that given that because they do not shut the dopaminergic pathways down, the nigrostriatal pathway will be able to function properly. Now, gang, the risk of extrapyramidal symptoms is not zero, but it is lower, significantly lower, but so it's not zero. So if you have a patient on these medicines, you still have to watch their gait, their affect, and so on and so forth. So here is a list of the second generation antipsychotics. And you're probably going to look at that list and say, my word, that's a lot of drugs, to which I'll say, yeah, you're right, it is. Let's go over them. Aripiprazole is the one that goes by the trade name Abilify. Does that ring a bell? It's one of the newer ones. It's in generic now, though. Very useful drug. It is definitely one of the best tolerated of the antipsychotics. Aripiprazole is a D2 receptor partial agonist. Partial agonist. Notice that one of the caveats of these drugs, they cause weight gain. Some of them cause a lot of weight gain. Aripiprazole seems to be largely weight neutral, but some patients will gain weight on it. So what are you going to do to your patient on aripiprazole? You're going to, here's the scale, step on it. And you're going to buy a scale at home. You're going to watch your weight. And you're going to go on a diet and exercise program. So you recommend to them, you recommend to a dietitian, and then maybe a personal trainer, sports coach, something like that. In Great Britain, I'm not kidding, this is real. In Great Britain, if someone is diagnosed with type 2 diabetes, and it's clear their type 2 diabetes is weight related, their doctor will literally tell them, pull out their script and write on the script the address for the nearest RSPC. Essentially, the doc's telling them to get a dog. Because dogs have to be walked twice a day. So the dog forces you to go for walks. Now you're going to tell your patient to get a dog? I don't know. They need a companionship, might be good, or a gym membership might be good too. Hard to say. Acenapine does not come in a tablet. It comes as a buccal wafer. You put it between your cheek and gum, and it gets released into the blood vessels in your buccal cavity. So acenapine is not as new as aripiprazole. It's still one of the newer ones. It's got a little bigger risk of weight gain and little bigger risk of increased prolactin levels. So that one you want to watch prolactin, whereas aripiprazole really doesn't have an increased risk of diabetes. There's a slight risk with acenapine. Brexpiprazole is quite new. That's the one that goes by the trade name. I forgot. Brexpiprazole, you can see, really doesn't have, it's pretty weight neutral, really doesn't increase prolactin, really doesn't have a very high risk of experimental symptoms. It's pretty safe. Brexpiprazole, by the way, has been approved by the FDA now for agitation caused by dementia. So that's another indication for it. Cariprazine, you get a higher risk of extrapyramidal symptoms with that one. It's weight neutral, but you got to watch movement disorders on that. Clozapine. Oh, buddy, look at the weight gain with clozapine. Yeah, clozapine causes substantial weight gain. That's one of the downsides of clozapine. Out of all the antipsychotics, by the way, clozapine is the only drug for which there's evidence that it decreases the risk of suicide. For that reason, if you have a schizophrenic patient who's a genuine suicide risk, clozapine is usually the go-to drug. Iloperidone is related to paliperidone. Iloperidone is one of the metabolites of paliperidone, so those two are kind of related. There's some increased weight risk, not a ton, but some. Extrapyramidal symptoms are an issue with paliperidone and prolactin. There's a risk of prolactin with paliperidone, not so much with iloperidone. Lurasidone is relatively new. Lurasidone is good if someone has weight trouble because it's weight neutral. Olanzapine is very effective, but weight gain is a huge issue with olanzapine. In fact, there is a new preparation of olanzapine. Let me find this here. Rexulti. Rexulti, that's what brexpiprazole is called, Rexulti. I just remember that. Here it is. Olanzapine is combined with a drug called samidorphan. Samidorphan is an opiate receptor antagonist. And samidorphan does decrease appetite cravings with olanzapine. So people on olanzapine plus samidorphan don't gain as much weight as they would on olanzapine. Somebody goes on olanzapine, it's not uncommon for them to put on 20, 30 pounds. It works. Great to take before bedtime. It knocks you right out. If you have a patient who's underweight, this drug can help them gain weight. But weight gain with olanzapine is substantial. Substantial. Quetiapine is used a lot in vets who have schizophrenia, usually related to the post-traumatic stress syndrome. Quetiapine will also increase appetite and will cause weight gain, not as much as olanzapine. Risperidone is used a lot in children because it's been tested and shown to be safe in children. With risperidone, the issue is the prolactin. My nephew, who's on the spectrum and tends to have meltdowns if he doesn't get medication, he's on very low dose risperidone. He tolerates it very well. So within a certain dose, some people do tolerate it quite well. Then there is ziprasidone. That goes by the trade name Geodon, I believe. With ziprasidone, one of the issues is it can elongate the QT interval in the ECG. The other one that can do that is iloperidone. If you combine these drugs with other drugs that increase the QT interval, what happens if you increase the QT interval? What can that lead to? Do you remember? We talked about that in pathophys. Yeah, I know it was a long time ago, but it's French. Torsade de pointes. Torsade de pointes. If the QT interval gets too long, this could be one of the side effects. And remember, that arrhythmia is nothing to be messed with. That can lead straight to VFib. And you go straight to the morgue, essentially, unless you're in the emergency room. But so drugs like that, you always want them. They should have an ECG before they get on the drug, and then they should have ECGs while they're on the drug. And you should avoid anything else that elongates the QT interval like the plague. All right, so clozapine, as we said, is your big gun. It can cause granulocytopenia in about 1% of patients. Most psychiatrists I've talked to have said if they don't get the granulocytopenia within the first year, they're probably not going to get it. He says, well, several of them said, the risk goes down. It will also cause orthostatic hypotension, bradycardia, syncope. What's syncope? Fainting, right. Lightheadedness, fainting, correct. Clozapine causes remarkable gastric hypomotility. The drug really plugs you up. So, what are you going to recommend to your patient? High fiber diet. You layer on things like Colace, things like Senna, things like that. You layer on essentially some of the different things that can help get the food tube moving essentially. Myocarditis has been reported. It's fatal if it occurs. Doesn't occur very often. And if it does occur, it usually occurs early. Olanzapine big time weight gain. Also can be sedating. It's rare, but so-called DRESS, drug reaction with eosinophilia systemic symptoms, has been reported, but rarely. So, and that if it occurs soon after they go on the medicine. On olanzapine, people really need to have their lipids watched because their LDL profile can really go up. So these two are put together because of their similarities. Risperidone can cause akathisia. Akathisia is a deep need to move. Watch these videos online. Some of them are pretty short of people with akathisia. There's a guy interviewing someone with akathisia, and literally he's got this restlessness, this deep need to move. That is a potential side effect of several of the second generation antipsychotics. Haloperidol, remember, is the active metabolite of risperidone. And it can elevate prolactin. That's one of the big ones. And QT interval prolongation is also a potential issue. And the drug is sedating as well. So if the drug is sedating, make sure they take it before bed. Quetiapine, also sedating, can cause weight gain, can increase your blood sugar. The drug insert says that there are potential ophthalmologic side effects and that patients should see their eye doctor once a year. There was a report that looked at people who'd been on quetiapine for 10 years and their rates of eye issues, and they didn't find any eye issues. So I'm not sure what's up with that. Maybe it came out in the clinical trials and so it was recommended. I don't know. Ziprasidone in some people can cause weight gain. On the average, ziprasidone is pretty weight neutral. The issue with ziprasidone is the QT interval elongation. Beyond that, ziprasidone is relatively well tolerated usually. So aripiprazole is less likely to cause weight gain. There have been reports of impulse shopping, impulse eating, that sort of thing, but those are rare. Brexpiprazole is even better tolerated than aripiprazole. So these two drugs are being used quite a bit in schizophrenics. And yeah, here's the newest of the antipsychotics. Lumateperone. Lumateperone antagonizes the D2 receptor and the serotonin 5-HT2A receptor, and that's it. So the drug is very clean in that regard. Doesn't interact with any off-target receptors. So it is approved for schizophrenia, and it's also approved either as a monotherapy or as an add-on to lithium or valproate for bipolar disorder. This drug is relatively new. So there's not a lot of data on this drug. Any questions on the antipsychotics? So what's the one? Is that a question? Yeah, go ahead, Grace. A lot of them interact with the histamine H1 receptor in the brain. Histamine H1 receptor, besides being involved with alertness, also seems to be controlled seem to control appetite. So that's one of the receptors that they seem to affect. Also, there are serotonergic pathways that increase appetite. And these drugs are also serotonergic. So those drugs seem to activate appetite from two pathways. Olanzapine, interestingly, there was a really interesting paper. Where was it published? Can't remember where it was published, but it looked at normal volunteers. We're not obese, we're not diabetic. They took olanzapine for like a week, and within a week already their blood sugars were above normal and their lipids were up. And some of them did not record huge increases in calorie intake. So these drugs affect lipid profiles and blood sugars independent sometimes of calorie intake, which is a little bit frightening. So that is an issue. And if you have a patient on these drugs, make sure that their weight is being monitored regularly and they really need to be on a diet and exercise program. There was an interview I saw on YouTube of a patient who she bounced around different antipsychotics. The one that just worked all the time was olanzapine. And she put on like 35 pounds. And then the hospital, she became part of a research project with the hospital. And it was, they were assigning them trainers. And so she got with a trainer. The trainer gave her a dietary program. She was able to lose like 25 and 35 pounds. So she's 10 pounds heavier than where she was, but she's been able to hold steady while she's on the olanzapine. And the interviewer asked her, well, are you hungrier? She said, a little, but I seem to be able to just throw it off because I'm kind of used to it now. So I was kind of, yeah, go girl. So it can be dealt with, at least by some people. Sorry?
Does it cause the body to like hold on to some of the fat explosions, or is it
That's a good question. I don't think that's known from what I've seen. Does increase appetite, does increase intake, and does increase serum LDL. Whether it causes body to hold on to fat reserves, I don't know the answer to that. I just don't. Okay. Now, before we take our break, so for our break, before we do our break, the one side effect that is the most feared side effect of these medicines is a set of movement disorders that's called tardive dyskinesia. Now, tardive dyskinesia was much more common with the first generation antipsychotics. Its risk is lower with the second degree antipsychotics, but it can still happen. And so if you have a patient on these, you need to know the signs, because if they get tardive dyskinesia, sometimes it doesn't go away. So this is really vital you're able to spot this when it emerges, because it's not anything to mess with. All right, let's take our break, 5 minutes, we'll come back, talk about tardive dyskinesia. Lisa, do you have any questions?
No, not right now.
Okay. This one? Yeah. It's like it's movement disorders. It's right under antipsychotics. And then I'm skipping the first part of it and just going to slide, I think it's 63. Or a second method. Slow into negative response to something. It's negative because so it's calcium is one.
I realized that after lunch. But it's
I record.
Would you guys have, oh, so last time I asked about- yeah. Yeah, that was.
Oh, okay.
You guys said you guys, yeah. Yeah.
Here, you think? I just. I'm just looking up the trouble right now.
Like the white loud version. It will have like a special like ribbon that says perfectly. Did you not think they got?
I did, I just didn't look at it, because I think.
I'm just gonna put the link.
Dawn, did Summer find the file?
Yes.
And she has, okay, good. All right, folks, back in the saddle we go. So tardive dyskinesia is a hyperkinetic or fast movement disorder, and it's associated with prolonged use of dopamine receptor blocking agents. So the typical manifestations will be things like chorea. These are semi-purposeful, regular sorts of contractions. Then there's so-called athetosis. That's kind of writhing motion that you might get. It tends to be a slower motion. Dystonia is a sustained and uncomfortable muscle contraction. Dystonias very often are seen in the face. You'll see things like something like that. Those are dystonias. They can sometimes cause a twisting, repetitive movement. They can cause even fairly abnormal looking postures. They can also cause somewhat stereotyped behaviors, lip smacking, chewing motions, things like that, pursing of the lips, repetitive tongue movements, things like that. One of the first places you tend to see tardive dyskinesia is in the mouth. So they'll, stick their tongue out, purse their lips, that sort of thing. So the tardive symptom is a broad term for a range of delayed onset sort of movement disorders. These are abnormal involuntary movements, and they're named based on the specific way they manifest, essentially. They will occur usually a year or more after exposure to the agent, typically. A tardive chorea is rapid contractions of the limb, the face, or the trunk, and they tend to flow from one muscle to another. That's a tardive chorea. The next is a tardive dyskinesia. This is a classic fast, repetitive, rhythmic movements of the oral, lingual, and buccal musculature. Tardive dystonias are these sustained muscle contractions, usually in the neck. They can also be of the shoulders sometimes. You might get hyperextension of the arms or the legs, or you can get something called a blepharospasm, where you get this closing of the eyes, that kind of spasm sort of thing, or the jaw, that sort of thing. Tardive myoclonus are these very rapid, brief, shock-like jerks, and they usually involve all the upper extremities. And then finally, tardive tics. And these are stereotypical movements, usually of the head and neck and maybe face. All of these can be parts of tardive syndromes. They can all be the result of dopaminergic medications. So how often do they occur? There was, fortunately, a meta-analysis. It was published in 2019. I realize that's very hard to read. It's just, well, I don't know. You guys read better than I do, but okay, Howard, we can't read it, but they can. This meta-analysis took a bunch of studies and put them together. And in this meta-analysis, they decided it was 56 studies, 35,000 patients. And they said about 1 in 5 patients treated with dopaminergic medications had some sort of tardive dyskinesia. 1 in 5, gang. Little troubling, huh? So some 19 studies looking at about 11,000 patients, not exposed to antipsychotics. The sort of phenomenon of tardive dyskinesia is about 5%. All this to say that antipsychotic drug exposure is clearly a factor in the onset of tardive dyskinesia. So the incidence of drug-associated tardive dyskinesia is increased in older patients. It can be up to 8% more in older patients. That's something to keep in mind. The clinical course of tardive dyskinesia is that it tends to begin over the course of usually days or weeks. It can emerge after the dose has been reduced, almost paradoxically. It can happen a year or more after someone's been on the medication on a steady dose, and then it tends to emerge. So it's somewhat insidious in its emergence. If you take them off the medication, remission is more likely in younger patients. About half the time you don't get remission, about half the time you do. If you take them off the medicine, it can take months or even years for the abnormal movements to go away. They don't go away right away. 3 years is frankly pretty typical, according to a 2016 paper. Risk factors for tardive dyskinesia, of course, older age. Women. It's more common in women than it is in men. And it's more common in those of African American ethnicity. So if you hit the trifecta for those, your risk is definitely higher. Traumatic brain injury seems to be associated with tardive dyskinesia sometimes. Sometimes. Long-term uncontrolled diabetes also seems to cause tardive dyskinesia sometimes. The other drug that is used for the GI tract, if you use it for a long time, this can increase the risk of tardive dyskinesia, is metoclopramide. This goes by the trade name Reglan. That's a dopaminergic medicine as well, and it can also increase the risk of tardive dyskinesia. So what causes it? Nobody knows. The suggestion is that the nigrostriatal receptors get upregulated. Structures in the changes of neurons or receptors, or some imbalance of the D1 and D2 receptors in the indirect and direct pathway. GABA blockade of the D2 receptors, nobody knows. Nobody knows. So key points of all this: tardive syndromes are delayed onset, they're abnormal, they're involuntary, and they're caused by medications that disrupt the striatal dopamine system. And antipsychotic use is the most common cause of tardive syndromes. And tardive dyskinesia is the most typical presentation of tardive syndromes, usually characterized in the lingual and orthobuccal, orobuccal musculature. Increased risks are seen in older age, female gender, and African American ethnicity. Also, pre-existing brain damage and diabetes can increase the risk as well. So patients should be diligently monitored for tardive dyskinesia if they're on an antipsychotic. And by the way, whose job is that? It's yours. You're the nurse. It's yours. Okay, so we talked about remission already. It's remission rates lower in the elderly than in young people. Symptoms usually don't get worse, but they can become permanent if they don't remit within a year or two. So to avoid tardive syndromes, the best way to do this is to use the lowest effective dose. Furthermore, when accelerating dose, you always want to go slowly. You can withdraw the medicine or you can switch to another medicine. Simply because if you take them off the antipsychotic, their psychosis may come back. Also, there are some medicines that are known to improve tardive dyskinesia symptoms if you switch them to it. The big one is quetiapine. If you switch people to quetiapine, that seems to improve tardive dyskinesia symptoms. That's why switching is a potential strategy. So the treatment of tardive dyskinesia symptoms, the first line, are the second generation VMAT inhibitors. And there are two main drugs. There's deutetrabenazine and valbenazine. So you can see that these drugs will both tend to make you sleepy. Valbenazine can prolong the QT interval. It can also cause some Parkinsonism. That seems to be dose dependent. Deutetrabenazine can cause some anticholinergic effects, dry mouth, fatigue. It is used for uncontrolled chorea movements in people with Huntington's. And there's a black box warning for increased suicide risk. Having said that, it's not clear that the drug causes that because people with Huntington's are at increased risk for suicide anyway. So does the drug cause that? That's why I have the risk, the black box warning. Huntington's chorea is a neurodegenerative disease that tends to affect the GABAergic machinery, wiring, neurotransmission in the brain. And so you start to get uncontrolled movements, choreas. You tend to get spasms like that. And these drugs do help with those choreas. Now, those can be very painful sometimes. They can, you just tense. It's, yeah. So tetrabenazine is a first generation. And first of all, this drug doesn't work that well. Secondly, it's not as well tolerated. So first generation VMAT inhibitors are just not recommended. Anticholinergics are used, but they don't work. And they got a boatload of side effects. So why kill yourself, you know? Clozapam, which is a benzodiazepine, seems to improve tardive dyskinesia. It's a better option than anticholinergics. And strangely enough, ginkgo biloba. You guys know what ginkgo biloba is? It's an herbal remedy. It's well tolerated, and there's as good evidence that it works for tardive dyskinesia as clonazepam. So who'd have thought? So upshot is that clonazepam and ginkgo biloba should be used before you ever use any anticholinergics. Amantadine is used for extrapyramidal effects of antipsychotics. It doesn't work for tardive dyskinesia, so don't use it. Botulinum toxin has been used. There are case reports that it might work. There just aren't any big studies evaluating it, so it's not recommended. Deep brain stimulation is used in severe tardive dyskinesia. No real good evidence it works. So if we summarize, you use your lowest effective dose of your dopamine blocking agent, or you switch to an agent that tends to improve tardive dyskinesia. Your first line are your second generation VMAT2 inhibitors. And then you can supplement with clonazepam or ginkgo biloba. So key points, minimally effective dose. Get up to that minimally effective dose slowly. Consider a dose reduction or cross tapering with either clozapine or quetiapine. First line treatment, second generation VMAT inhibitors. Clonazepam and ginkgo biloba can improve symptoms and are well tolerated. And there we are. Any questions about tardive dyskinesia? Yeah, yeah, just the ones I went over. Tardive dyskinesia. Because the NCLEX likes to ask about tardive dyskinesia. I would recommend you get on the web, get on YouTube, put in tardive dyskinesia and just watch. There are some videos of people with tardive dyskinesia so you can recognize it. When you see it, you'll say, okay, I know what it is now, and you'll know how to recognize it. Okay. Any questions before we move on? Well, now we come to some particular drugs that are central nervous system depressants. So of these drugs, barbiturates are really not used that much anymore. They're used for bad seizures. That's really about it. Benzodiazepines, however, definitely have a role for anxiety and sleep aids and so on and so forth. So barbiturates are a class of the so-called sedative hypnotic medications. Like the benzos, they suppress the central nervous system. So they're very good for seizures. They've been used in the past for insomnia, but not so much anymore. But they will put you to sleep. Because they suppress the CNS and they just make you feel groovy, they are used or have been used for preoperative treatments. Have been used for migraines, not so much anymore. And they have been used to decrease intracranial pressure. Now, if you see a drug that ends in barbital or just ends in ityl, it's probably a barbiturate. Barbiturates have no antidote, and even narrow therapeutic window. The other thing about barbiturates, they're habit forming. So you give someone a barbiturate and they ask for more, what are you going to tell them? No. No. So you get to stand in front of the mirror and practice no. Because sometimes you need to tell your patients, I'm not convinced. Tell them, thank you, no. So here are some of the barbiturates. Phenobarbital is kind of the best known out of this group. Pentobarbital is used in veterinary medicine to put animals down. There's secobarbital, that's a preoperative sedative. Butalbital is used for migraines. Evidence base for butalbital is not great. It is used, but not that much. Methohexital is used in some anesthesia cocktails. So how do these drugs work? They bind to the GABA receptor. They increase the length of time that the GABA receptor remains open. Remember, the GABA receptor is a chloride channel. Chloride comes in to the cell and hyperpolarizes it. If you hyperpolarize the neuron, Can it form an action potential? No. It's hyperpolarized. You can't excite it, so it is a central nervous system depressant. At high doses, barbiturates can bind to GABA receptors and cause them to open without GABA. So it can really suppress the central nervous system. So the GABA A receptor, which is the target for barbiturates, it's found throughout the limbic system. What does the limbic system mediate in your brain? I don't speak mumble. Fear, emotion, experiences, those sorts of things. So when GABA binds it, it opens, chloride channels rush into the neuron, hyperpolarizes it, inhibits it. So GABA is an inhibitory neurotransmitter. Barbiturates potentiate the effects of GABA. Therefore, our central nervous system depressant. So here are your nursing responsibilities. I have a silly little mnemonic, barbits. Barbits B, barbiturates bind to different sites on the GABA receptor, then do the benzodiazepines. At higher doses, they can open the channel without any GABA. So at higher doses, they're extremely potent CNS depressants. And the drugs have a low therapeutic index. So B, they bind. They bind the GABA receptor. A, abuse, addiction, and dependence are high risks. So here's questions you're going to ask about your patient. Do they have a history of substance abuse? Do they have a history of suicidal ideation? If they do, they probably shouldn't get a barbiturate. R, recognize the signs of overdose. Does the patient require mechanical ventilation? Respiratory failure is one of the main presentations of barbiturate overdose. So the signs and symptoms of overdose, we're going to use the mnemonic lethal. I'm really proud of this one. Lethal, loss of consciousness, pupils of the eyes, eyes. They dilate and are fixed as the body shuts down. T, tachycardia. Tachycardia. Jade, what does tachycardia mean? Heart beats too fast, right? H, they have cold, sweaty skin. Cold, sweaty skin. A, absent reflexes. And L, low and shallow respirations. Those are the signs of barbiturate overdose. Know them, recognize them. R, recognize the signs of overdose. B, be aware of patient safety. Patients will be relaxed. They'll be euphoric. They won't be able to think clearly. Should they sign any papers that day? Survey says, not in your life. Make sure the bed's not too high. Bed's too high, they're going to take one step out of bed and go kerplunk. Break their hip in the hospital. Hello, Sam Bernstein? You want to keep the bed low then, so they don't get out of bed and fall. They may fall anyway if they get out of bed, but it's not because the bed's too high. Hopefully they'll ring you before they get out of bed, because there's probably going to be a fall risk, and you could put the white belt on them and keep them from falling. Don't let the patient get up without help. No important decisions that day. I. Is there a risk? I for is. Is there a risk of accidental overdose? So take the drug as also I instructed. Take the drug as instructed. Don't mix them with things that potentiate their effects. Don't mix them with alcohol. Don't mix them with opiates. What if their friends come and visit them? Hey, Al, you survived. Here, we brought you some whiskey. Yes, you escort them out of the hospital. You call security, and then you tell them, thank you, but no thank you. And then you come back cursing under your breath how stupid his friends are. Anyway, these drugs have a low therapeutic index. So phenobarbital levels should be between 15 to 40 micrograms per milliliter. That's a number I need you guys to know. So you're going to write that one, put it on a post-it note and stick it on your mirror and look at it every day so you'll get that one in your head. Between 50 to 40 micrograms per mil. 15 to 40 micrograms per mil. T, tolerance. People can become tolerant to these drugs. They need more and more and more. Get the same effect. And S, stopping the drug abruptly can cause withdrawal symptoms. Those withdrawal symptoms can be dangerous, so you're going to step them off the drug. So let's review. Binds to the GABA-8 receptor. Abuse, addiction, dependence are high. Recognize the signs of overdose. Be aware of patient safety. Take the drug as instructed. The drug can lead to tolerance, and don't stop the drug abruptly. Barbiturate withdrawal, we're going to use the mnemonic craves. Crave, C, convulsions. R, restlessness. A, agitation. V, vomiting. E, elevated temperature. And S, sleeping problems. These may be severe. They can lead to shock and to death. So you always step them off barbiturates, especially if they've been taking them for an extended time. Always, always, always. Questions about barbiturates? Let's go to the benzodiazepines. These are also CNS depressants. They're used for anxiety. They're used as sedatives, and they're also hypnotics. Some of them are quite potent, some are less potent. Some are long-acting, some are short-acting. And my mnemonic is short Tom, medium cat, long divorce. I'll explain that here in just a bit. So Tom Cruise is quite short. He married Katie Holmes. You can tell she's taller than him. And so short Tom, medium cat, long divorce. Their divorce, you guys don't remember this, you were too young probably, was really long and drawn out, and it was kind of pathetic, but it gives us a nice mnemonic from pop culture for the benzos. So if you see Z or Zo in the drug, and if it ends in Lam or Pam, good chance it's a benzo. Of course, there are chlorazepate has a Z in it. And then chlorodiazepoxide, there's your Z. Those are examples of your benzos. So short Tom, TOM. Triazolam, oxazepam, midazolam. Those are three short-acting benzodiazepines. Short-acting benzodiazepines. Medium cat. Okay, I had to cheat on this one, but it still works. Clonazepam, alprazolam, lorazepam, but it's called Ativan, and virtually every hospital where I've been, they call it Ativan. And then temazepam. So CAAT, medium cat. These are the medium acting benzodiazepines. Long divorce, DVC. Flurazepam, which goes by the trade name Dalmane, there's D. Diazepam goes by the trade name Valium. And then chlordiazepoxide, that goes by the trade name Librium. And that's your C, that's your long divorce. These are the long acting benzodiazepines. So short Tom, medium cat, long divorce. So let's go over them again. Triazolam. In fact, I'm going to say them, you say them after me. Triazolam, oxazepam, midazolam. Those are short acting, short Tom. Clonazepam, alprazolam, lorazepam, temazepam. Those are medium acting, medium acting. Then the long acting ones are flurazepam, diazepam, chlordiazepoxide. Those are your long acting. Did you butcher that one, Summer? Those are your long acting benzos. Short Tom, medium cat, long divorce. What are they used for? There are some that are indicated for seizures. We'll get to those when we talk about anti-seizure meds. They're used a lot for anxiety. That's one of the main things they're used for is anxiety. They're also used for ethanol withdrawals. They're used for panic attacks, insomnia. They can, midazolam in particular is used to calm people down before procedures. Some people, like yours truly, get really nervous before procedures and their heart just goes pitter-pat and their blood pressure goes wee. And so midazolam can help you. Just warn your patient, if they get midazolam, they're going to wake up drunk. That stuff, the hangover with that stuff is bad. So just keep that in mind. They come in lots of different formulations for administration. So they come in oral, IV, intramuscular, and also suppositories. So the wide range of ways to give these drugs. These also act on the GABA receptor. Instead of causing it to open more for longer, they cause it to open more often. Chloride ions flood into the neuron and hyperpolarizes it. They're CNS depressants, but they do not act on the GABA receptor in the absence of GABA, regardless of their dose. That's a big difference. So nursing responsibilities are mnemonic as benzo. Benzo. These drugs are on the Beers list. Anybody know what the Beers list is? Howard, what's the Beers list? Oh, come on. You've seen the Beers list probably. You take care of older people. Those are the drugs you tend to either avoid or use with great caution in elderly people. It's a Beers list. And rest homes will usually have a Beers list around somewhere that you're supposed to avoid these drugs or really use them with caution in elderly people. So benzos are on the Beers list. They can increase the risk of falls in the elderly. To avoid ethanol when you're on these drugs or opioids or other CNS depressants, a lot like the barbiturates. And not recommended for long-term use because of the risk of dependence. These are not as habit-forming as barbiturates, but they're still habit-forming. The sleepy, they're sleep-inducing, they're hypnotics. So you don't want to take them while driving, don't want to take them while operating heavy machinery. Oh, overdose, the antidote is flumazenil. Flumazenil. You're going to use this drug if the benefits outweigh the rest of the drug, because that drug is not without risks. Signs of benzotoxicity are mnemonic is abused. Abused. A, altered mental status. B, bradycardia. U, uncoordination. S, slurred or garbled speech. Slurred or garbled speech. E, they experience memory loss or hallucinations or something like that. D, decreased respirations. And keep in mind the tolerance can occur as patients take more and more and more of their benzodiazepine. There's a group of benzos called Z drugs. They are sleep aids. We'll cover those when we cover the drugs for sleeping. Any questions about benzodiazepines or barbiturates or anything we've talked about tonight? Folks, I know it's a lot of drugs. I told you this was going to happen. Think I was kidding? Well, now you know I'm not. It's kind of going to be this way every night. So, here's the deal. Sound like Ross Perot now. Here's the deal. You will need to go back to your place of residence. You're going to need to go over these. You need to sit there and read through them, read through the drugs. I think for you as nurses, being able to recognize the drug. So if you see it on a piece of paper, maybe you can't rattle it off the top of your head, but if you see it and you recognize it, like if it's you on a quiz and you recognize it, that's what you want to be able to do. Recognize it. You see midazolam, you know, benzo, short acting. If you see phenobarbital, you know, barbiturate for seizures. Then you start to think of some of the things you need to watch for in a patient with it. Same thing with antipsychotics and stuff like that. So that's what you're going to need to do each time. So quiz on Wednesday will be over what we've covered today. All right. See you guys on Wednesday. There for you. Liesel, Lord bless. Have a safe trip. Take care, all right?
Thank you so much for Zooming tonight.
Absolutely. Good night to you, dear lady. Be safe.
Have a good night.
All right. Bye.